What's up, folks? Guerrilla Radio episode 19, back with Dr. Nagel at his office at True Wellness Chiropractic. So what we're doing this time is this will be a 4-part video series on slaying the dragon that is low back pain. It's something I've dealt with for 13 years. Being in the gym business for the last decade, it's one of the most chief complaints I have. Obviously, Dr. Nagel's been involved with it for at least a decade now, dealing with low back pain. He's dealing with it every single day. And we know statistically that 80+% of Americans will experience it at some point in their life. So it's just a tricky thing that you have to stay ahead of. Like I said, I've been dealing with it for over a decade, but I have to stay ahead of it. If I don't, then it comes back. So we're going to just kind of, this first episode is going to be all about understanding what low back pain is, what's the driving cause, and then we'll talk about prescriptive treatment, doing some functional screenings, mobility, stability stuff in the next couple of videos. So obviously, he's the expert on the spine and low back pain especially, so we wanted to jump into mechanism of injury. What is, and you had a great point. Before we can talk about abnormal, let's talk about normal. So let's dig into what it is to be a normal in terms of what your back health would look like, your spine health would look like, and then what deviates from that.
So there's a couple things that affect it. That when we look at the spine, it's established in like we talked about in orthopedics, that in biomechanics, that there's normal shape and normal structure of the spine, right? And generally speaking, what we explain is that looking front to back or back to front, it's logical that everything should be straight, vertical, right? With that being said, at the pelvis, specifically with low back pain, the legs should be even, and then the base of the sacrum, so the sacrum, the way it sits, it should be a horizontal base, because that's the foundation.
And the sacrum is the most bottom segment of the spine.
The very bottom. It's the tailbone right through there.
Tailbone, okay.
Right? So if it's sitting at an angle, whether it's because the leg is short, or sometimes it's because it just grew funny, right? It's called a morphological change. If it sits like that, you'll see a correction through the spine, because the spine, your head wants to get over the center of gravity, right? So you'll see a list, or you'll see a curvature, you'll see an abnormality there. But that's going to create chronic abnormal stress on the L5 disc or L4 disc, depending on what's going on there. Right?
So is most of that pain then an evolving of the disc issue itself, the disc itself, or where does most? If I say I have general, my back is just always achy, what is that typically driving from?
Well, that's
a huge. I know, my Pandora's box. But.
Yeah. I mean, that can be driven from the facet joint, which is very, very common. Those are the joints on the very back of the spine. If you have a damaged joint, you're always going to have muscular involvement, so the muscle might be actually driving some of it.
Okay.
And then always the disc has got some level of involvement, in almost every case. One last thing on the normal value, from the side though, you should have normal curvatures as well, right? You should have, we tell patients 40, right? 40 degrees in the neck, 40 degrees of sagittal curve. Thoracic spine should be set at 40 degrees, lumbar spine should be at 40 degrees, and then the sacrum. And this is why this is so important. That when you say what's it being driven from, I can literally look at the X-ray and based on those angles, you can, even without hearing symptoms, you can get a pretty good predictor of what's going to be worse. Meaning that if I've got a chronic, or if I've got a pelvic tilt that's very forward, right, that could very much be more likely to be a facet joint. And here's why this is important. Why I talk about X-ray, the number of times that you look at someone's posture. And you might see they look like they got an anterior pelvic tilt, right? Where it looks like they're sticking out. Mm-hmm. And then you take an X-ray and they got a really shallow curvature. That's just the shape of the sacrum that you're seeing. You're not actually, it's better than not looking at anything, but it's the only way to accurately see it. You've got to see what's going on with the structure.
Okay.
Okay?
So I think, go ahead.
So likewise, if I see somebody who has a very straight lumbar spine, I know that they're going to be much more prone to disc problems. I know that for a fact. Secondly, posture, because this is something that people can. We'll go through some screening stuff with posture. The thoracic cage is the biggest mass, right?
Okay. So the thoracic is
from here to here. It's where your ribs are.
Okay.
Right? Protecting the heart, lungs. Since that's got the largest amount of mass and stability with the ribs, the lumbar spine and the neck tend to follow it. So if I'm looking at this side and I see the thoracic spine extend back, then I know I'm likely to see a really shallow lumbar curvature, or a sacrum angle. Instead of being 40 degrees, it's going to start shallowing up, and it's going to be under a tremendous amount of shear force like that, right? So that's going to create significant problems on the disc. And often correct times will act like stenosis, like when you see the elderly person hunched over, gets pain down both legs when they stand up. They're getting it because bone grew there because it's been in such bad position for so long.
So stenosis is the growth of bone over
around the opening, around where the nerve is, the spinal cord of the nerves,
okay.
right? So they get away from it by hunching. Well, when you have a posture like this, it creates something called functional stenosis. You can get a lot of the same stenosis symptoms, but it's 100% biomechanical. So likewise, if I see the thoracic spine carrying weight forward, right? Oftentimes you think of like that ballerina or dancer's posture.
Okay.
They're used to standing very upright, but they oftentimes then train a posture that goes forward, and that creates massive loads in the facet joints, the lumbar spine, and can create. That's one of the reasons you don't see a lot of old ballerinas, you don't see a lot of old gymnasts. Most of them stop because of low back injuries to the facet joints.
Gotcha.
So generally speaking, you said, where does it come from? The number one cause of back pain is by far, it's called biomechanical low back pain.
Okay.
But it can be driven based on what's being loaded. It can be driven by a bunch of different, the actual injury could be a bunch of different tissues.
Okay. So biomechanical, we're basically talking physics applied to the body, right?
Absolutely.
Okay.
Yeah.
So how we move.
Posture and dynamics, right?
Posture and dynamics. Love it. So I love the idea. I think it's a little comforting when for people who are maybe struggling with it to say, okay, we know there are normative values, right? And then by looking at it, and that's a professional level looking at it, not anything less than that, saying we are deviating from normal X amount, and here's some prescriptive treatment.
Absolutely, yeah.
Okay. So let's say if we're all, so we're probably all born outside of having congenital or born with defects in the spine, and we say biomechanical, break that down into, is it sitting posture, is it, so we'll talk about maybe the sedentary person and then maybe the active person, right? So the sedentary person, probably more than anything, weak core, no stability, maybe sitting too much, on the phones too much. These are driving forces for biomechanical changes for a sedentary person. Okay.
Well, here, let me put it a different way.
Okay.
When we look at what normals is versus abnormals, the likelihood, say you have a leg that's 10 millimeters short of the other. I'd really want to see your kids because it's very likely with multiple children somebody's going to have a short leg. And what's really cool with kids is you can do stuff to make that change.
They're so malleable.
They're malleable, and so even when the leg length is physically shorter, there's cool research that's come out in the last year and a half, multiple studies now that they show that if you actually lift them and monitor it properly, but lift them properly and do that right mechanism, you'll actually stimulate that short leg to grow faster through something called Wolff's Law, which is a law of physiology. So you can get that to balance out. So unlike me, who if I don't wear a lift in my shoe, I start having a lot of problems. My kids are being monitored for that exact reason because if one of them does have an anatomically short leg, I'll be able to get ahead of it and it won't be a long-term problem. We can fix it.
Gotcha.
Likewise, they're very, very, very malleable, right? So your spine can grow. Your spine can grow normal, but it also doesn't necessarily grow normal, right? Those that grow normal, you can also create trauma, and trauma can remodel it. So that could be the kid that falls down the stairs, or even less significant than that. That could be your kid staring at technology 24/7, which just kills me.
Yeah.
Because we see the changes so badly now. We've talked about that before. But trauma will cause a remodeling process as well. That shape in the spine is held with ligaments. It doesn't take as much trauma as people think to start getting remodeling of the ligaments. So if you're not consistently doing things for spinal molding, if you're not consistently doing things for mobility, you'll get change. And if what you do all day is sit, then your spine will remodel and mold to whatever you're doing.
Gotcha.
You follow me? So that's a micro trauma, but when you do that every day for 25 years at your job,
don't think massive car accident, right? Trauma, it can be small stuff.
Yeah, and the bigger traumas we have are most frequently micro trauma, right?
Okay.
But you played contact sports, you got in a couple car accidents. For you, like the military, right? Hiking for massive quantities of time with massive amounts of weight on your back.
Right.
So that stuff can all play a role, and to us, fitness should be part of the rehabilitation process. And when you know what's going on, you know how to bias things for you, but ultimately we want fitness to be the rehab. Does that make sense?
Yeah.
One last thing is that I've always said this, that if you've got bad structure, your first line of defense is stability. Be strong. That makes a huge difference, regardless of the age. I mean, if you got bad structure, be strong. But if you can fix structure, fix the structure and be strong. That's a better solution every day.
Got it. So so we talked about about that sedentary, sitting too much, not doing much activity. I think it's been my experience, we can see some quicker results with people who we drop 40 pounds off of their gut and get them active and strong for a little bit, and then we see some improvements. Absolutely. I think perhaps a tougher thing to approach is the very active person who's 30, 40, 50 something, been very active, but now it's creeping on them, right? Maybe it's been this very small movement inconsistency that wasn't even visible, but it was there for whatever reason, and now the pain is showing as a result of whatever that case is. Give me some thoughts on how you approach that kind of stuff and what you do for that person and how you go from there.
So one thing I'll say is that pain is just inflammation, right?
Okay.
And what tends to happen is a lot of people don't think they necessarily have a problem. Excuse me. We don't recognize there's problems typically till we start having some type of symptom of some type, right? Mm-hmm. But we don't take care of our teeth that way. We preventively go in and get our teeth taken care of. And then most of us know that if a tooth hurts, it's usually
you're past, yeah,
right. Mm-hmm. Most people are told, "Hey, by the way, did you know you have a cavity forming?" No, I didn't. Mm-hmm. So on the flip side of that, the general public in our country typically waits till their symptoms. The problem is the spine. When you look at biomechanics, it's very predictable how it's going to decay and degenerate. We've seen modeling of that over and over again. And so if we wait till there's symptoms, it doesn't mean you're in phase 1. Right? You could be in phase 3 or phase 4, like late stage of degenerative change, before you have any symptoms.
So the later the stage, the worse your degeneration.
Much worse. And so one of the things you look at from that standpoint is, now step back, somebody's already at phase 3, what do we do? Well, if you've lost normal biomechanics there, so you've got now arthritis in the joints, the disc is maybe thinner, there's a lot of scar tissue and fibrotic tissue in the musculature around the spine. You want to essentially optimize what you're doing. You may have to start to modify things at the gym, whether it's short term or long term. Like I don't expect my dad with the years of wear and tear to be able to get as deep as I can in a squat, especially under load. Right? It doesn't mean you shouldn't squat. It just means find your functional range of motion and stay there. And that might change, which is kind of it's tough on your pride sometimes. Mm-hmm. But if it's what keeps you training, keeps you active, keeps you fit, then it's the way to go.
Yeah. So I think that's a good point too. So let's kind of give, because to me, I dealt with it for so long when I finally educated myself on it, to get this idea that there's, you're probably not completely broken, right? You can see change and you can improve upon it. So start in the triage process, right? Somebody's watching this and like, man, I've been struggling for low back pain for 5 years, 1 year, 10 years. First and foremost, go see a professional first to make sure that we're not on the verge of some massive rupture, we're not.
That's a big deal,
right. And if we're not there. What's then? You're in this category of I can make this better. So what would you say to that person then? How can they? What's the next steps for that kind of thing?
Well, you and I always talk about kind of the clinical approach we use, and it ties very much into the gym approach for you. Is we use kind of the modeling of mobilize, lengthen, activate, integrate.
Okay.
So breaking that down, mobilize and lengthen would be what can I do to get space? Because space and movement gets rid of chronic pressure, chronic tension, and creates freedom, right? Creates comfort. So one way to start working on mobility is things that most everybody knows now is stuff that nobody knew when we started doing it, using foam rollers, lacrosse balls, or PVC, whatever we can do for self-care, or deep soft tissue work, right? Mm-hmm. So with a lot, I've mentioned this to you before, when you look at MRI results on somebody who's had chronic spine problems, maybe the pain is new, but then when there's been like a biomechanical problem for a long time, you'll see the muscle in the lumbar spine right here. When you look at the MRI results, it should look like a fillet. It should look really clean, right? And you'll see striations all through it of connective tissue. So it's called fatty infiltration. You'll see that in MRI reports. So to us, that's stuff that needs stripped out. You gotta strip that out. And there's multiple ways to go about that. One would be like traditional massage. If you're only getting massage and you say, well, I'm gonna go try it once, it's not gonna do anything. You have decades of fibrotic tissue. You gotta beat on it, right? And you gotta mobilize it, and then you gotta lengthen it, because you gotta break up that scar tissue and then you want to lengthen that tissue so you get it to remodel and heal how you want. It doesn't just not back up. So the combination of getting good soft tissue work, whether you're going to somebody or not, but say you're going to a massage therapist, they're doing deep tissue focused on that area, busting that up for an hour. If you wait a month to do anything, you've made a tiny bit of progress.
Yeah.
So you're better off than hitting with lacrosse balls and doing some more of the movability stuff you teach on a regular basis in between. And if it's me, I'll tell you, like, if I was going to do it that way, I'd be going to a massage therapist at least twice a week and doing that stuff every day in between, mobilizing with home care, and then working on stuff to lengthen the tissue, right? If there's no disc involvement, this is important. If somebody's got a disc and if they don't know, this is part of the reason you got to know what's going on. If they're getting neurological symptoms down the legs and stuff like that, they need to check stuff out. If they're getting changes in bowel or bladder function, right, like not able to hold it, huge emergencies. If you're seeing atrophy or you've lost feeling, you got to get that stuff checked out. That stuff's no joke. That can become a significant emergency really, really quickly. If it's just low-grade, localized, low back pain that's just nagging and annoying, the likelihood is less that it's something like that. But if you're safe to do it, and like I said, you got to get cleared for it. Things like you've done for quite some time is inversion. So inversion can be absolutely fantastic short-term for the lengthening process, right?
Got it.
Things that I'm not as big of a fan of, especially if there's a disc, is rotational stuff. Because I've had way too many patients have a disc problem and when it came in from whether it was whatever professional gave them advice to lay on their back and stretch side to side, but it was actually a disc problem and they progressed the disc.
Made it worse.
So if it's just biomechanical and there's no disc involvement, then... So
can you fix a bulging disc or ruptured disc?
Oh yeah, I mean, it's going to absorb. If you get nothing, eventually it goes away.
Okay.
The body will absorb it. The model for us is a little bit different than others, because you could, if somebody's got a bulging disc, you could take drugs for it and get rid of pain and let it go away. You can do injections for it and let it go away. You can do nothing and just be tough and let it go away. We want to actually, when the stuff that we do when we're taking care of somebody and people that practice like us, is you want it to heal, but we want it to heal as strong as possible. So the disc itself is really a big, it's layers and layers of ligaments that have fibers that crisscross, right? Okay. So one layer it goes around and they'll sit this way and then they go this way. When you bulge a disc, it doesn't go from healthy to ruptured like that. It's a process.
Layer by layer.
Yeah, and a lot of times people mistake those small injuries over the time where it was tearing through this annular fiber. They mistake that, and it was what was a small injury to the disc. They're like, oh yeah, I tightened up. 4 or 5 days later, I was good. A lot of times that can be progression of the disc, and it kind of worms its way through until it finally hits a nerve root, and that's when you get referral symptoms, right? So the nerve root, let me grab it.
Yeah.
And so if you're looking at it, the center is like a jelly, and then there's layers like this, and so if it's worming its way through, there's some research that shows you don't have any pain sensation until you get to the last third. There's some of it that says the whole thing's innervated. It sounds like it's like the consensus is it's different from person to person.
Yeah.
So some people can have a progressing disc injury without a lot of symptoms till it's almost too late. Some people are more sensitive to it, can feel it right away. So number 2 is that when it finally bulges out and hits the nerve root that's actually going out to the organs themselves, that's when you'll start getting sciatica pain, things like that. Where it gets more complicated is if it herniates straight back, which doesn't happen as common, because those people tend to pass testing that you look for in orthopedics for a disc herniation. And again, I mean, that's something that someone that knows what they're doing, you can see it, but it's a little bit harder. And they're going to be a lot more compromised by sitting, by being in flexion, period, because it's going to promote that problems.
I think that's huge. I think that's eye-opening in terms of what is driving the pain itself and what is the progression of the injury, right? Yeah. It's not, because we've had this conversation too where people have come in not because they tried to lift a 300-pound stone and blew out a disc. They went to grab a coffee cup off the end table.
Which is where most
that was the final straw.
Yeah, when you're dealing with, especially with a disc problem, you can bang it up quite a bit, and a lot of times you don't get as hurt because you're creating a lot of abdominal pressure when you weight lift, right? Trying to stabilize it. It's the leverage that occurs at your spine when you're not conscious of stuff and you pick stuff up, which really, I mean, that ties into what you want to talk about is how do you screen for like abdominal discoordination?
Right.
How do you start retraining that stuff?
Yeah.
How do you retrain your body to stabilize before you move so it's not a conscious thing?
And that'll be next. The next one we're going to dig heavily into that. Dr. Nagel show us some stuff on functional movement screenings and what we're looking for and how you can even do some basic self-assessment stuff to see where you're at.
Self-assess.
Well, let's jump in. We'll finish up with. If you've been watching our episode, you know I have kind of a case study for some of these tests in the past. He's got, what do we have, 6 years worth of, maybe the first time I had x-rays was 6 years ago?
This is just the last x-ray that I took. But yeah.
So he's been able to follow 6 years, probably 6 years ago we did my first x-ray when I was first getting treatment here, and I've been in and out here for those 6 years. So we'll take a look at the most recent.
If it'll load up.
Yeah.
Let's see.
We'll do the most recent one, and then we can kind of see how, I think it's interesting how you can draw parallels between the style of weight training that I've done that can load that kind of thoracic flexion, as I'm catching a barbell into or doing heavy front squats or cleaning something like that, with not the best of techniques. Sometimes, you try to keep it as best you can, but you go for that PR every now and then, you try to go a little too heavy and you force yourself into a place you're not supposed to be. So what I've had to do over the last 18 months is totally step back in my training. And yesterday was the first time I touched a barbell over 250 pounds in 18 months, and I used to do that 3 or 4 times a week. So, but did it pain-free yesterday, and I'm feeling out better. So it is, you mentioned kind of it's hard to do, just check the ego.
Yeah.
Especially when you feel like you've been progressing for 2, 3, 4, 5 years, and it's like, wait a minute, I was progressing in weight, but I was chipping away here all that time. So now I need to take a step back and rebuild. And that's kind of the approach that we've been taking more and more over the last several years at the gym, is the long-term approach. I want to be doing something 70 and be healthy. Especially as you get older, it becomes less about let me PR my back squat, let me wake up pain-free, let me get up and off the ground without using support, and that's been more driver.
So I think this is important to note too. We have patients I've taken care of for years and years and years, right? Mm-hmm. They don't come in because we're trying to put out flames constantly on chronic pain. Most of them have had problems with whatever it is, but we do corrective work, we fix their spine. The reason they're still wellness patients is they're unloading life, right? Like they know, just like you create stress in your body at the gym.
Yeah.
Maybe it's a job change, right? Like I think I've told you how much my spine changed when we put together the weight loss program, because I was like this every day, like the average person, and so I had to go back and regroup and do the same thing. It's the same thing with fitness. Anything that you do routine is your body's going to specialize to it. So you went through where you were doing tons of heavy, like primarily you're doing everything, but towards Olympic weightlifting.
Yeah,
right?
yeah.
And which is fantastic, but it's going to start. It still will create an asymmetry. Mm-hmm. Does that make sense? Mm-hmm. It might not be your hamstrings to your quadriceps or something, but it still starts to create asymmetry because it's more front loading than say a powerlifter. We see very characteristic structural change in powerlifters too, that are primarily low bar back squat, mm-hmm. right? Sumo deadlift or whatever, deadlifting, low bar back squatting, and bench press. They tend to have a very common look. A gymnast tends to have a very common look. The ballerina. So it doesn't matter what it is. I think that if you do it all the time and you don't ever have a recheck, right? Yeah. You're going to start create biases, and the further you get down that road, the more risk you have to any type of injury.
Yeah. Okay. So let me make sure. I'm going to zoom this in just a little bit so we make sure we're good on that. I think we can see it all right. All right. Go ahead. I think we're good.
So this is one of the softwares we use when we do analysis, X-ray analysis. So the left side over here is normals, and I don't know how well you can see it or not. And then patient values are on the other side. So the green lines follow normal structure, normal curvature. And same thing over here. The green line is normals. The red lines are what is happening. And then we have all the measurements and printouts come out the bottom of this. So with Justin, though, one of the things that we saw was that his thoracic spine in general had shifted back. So it started to come this way. And in doing so, you see that the abnormal lines, instead of this side where everything lines up perfect, the ligament structure looks good. His wasn't like that. You see a lot of the posteriority I was talking about, right? So you had a lot of symptoms in your low back. So what we're talking about, that functional stenosis symptoms.
Oh, yeah. Okay.
Remember we talked about that? So we did a lot of stuff in the office, and most of it was done at home for traction work to reshape and restructure a lot of this. But what we were working on was getting his thoracic spine to come forward, and his thoracic spine from here to here to also be working to come forward, right? So that was, in general, that was one of the things. And what made yours more challenging and made it something where we had to do more stuff in the office was your sacral base ankle. Like I said, usually that's going to start to come more shallow, right? And put more load on the shear load on the disc. Yours stayed really, really steep, and the concern with that was that with that staying really steep and your back coming back like that, it really puts an abnormal load then on the
Gotcha.
L5 facet as well.
So and I've heard the analogy, tell me if it's appropriate, that the pelvis is kind of like a fishbowl, and then tilting it, you don't want to spill the water in or out of it like when you're doing any sort of movement with any load?
Yeah.
Is that an appropriate analogy?
It is, but here's what makes it complicated, but it's not that hard for the person, people to understand. This circle right here is one of your hips, and I think that should be able to be seen. If I look at where your hips are, and I look at the shape of your pelvis here, there's measurements we take because not everybody's got the same shaped pelvis.
Gotcha.
Right? It's called pelvic morphology. So in some people, although we know 40 degrees and 40 degrees is biomechanically at your advantage, some people can never have that, and their normal might be 30 degrees. It might be 25 degrees. That's stuff that, that's one of the things our software counts for, but that's stuff we measure to see.
Gotcha.
Does that make sense? So if somebody's got a very straight spine, and our goal might be get 10 degrees. And that might, if they're a neutral spine, like a 0 degree curvature, straight spine like a broom handle, they might never be able to get past 10 degrees, but if we can keep them near 10 degrees, and that's their bottom, their spine's going to age better. Their risk of problems long term is going to be less. Does that make sense?
Yeah.
So with anything, whether you're doing training in the gym or you're doing this stuff, it's about what's the potential for them, and where can they get, right? What's the potential? Where are they going to get the best bang for their buck in terms of time, energy, everything else? And then how can we get them there and keep them there?
Okay.
Does that make sense?
Yeah.
So it's correct it, and then how do you stabilize that and teach them how to do self-care to maintain it?
Okay.
Here's what's interesting though. That person that has that, they're born, that's called a morphological change. They're born with a different shape. If they have a morphological change in their pelvis, you can't quite give the same coaching. Like when you're giving coaching, it's kind of like us too with stuff. You give broad strokes because you hit the 80 or 90%, right? Well, that 10 to 15, maybe 20% that has those changes might need really specific training. Like with yours, we were talking about, you have a steep sacral base angle, so where extension, right? Like the old school coaching would say hyperextend and get that good curve in your lumbar spine. If you do that, you're actually going to keep making that worse.
Just make it worse, yeah.
So if we're watching you in a squat and you initiate the squat by going to extend in your lumbar spine, I don't know if that can be seen or not.
Yeah, I'm going to back that just 10.
Okay. So pattern-wise, if we're training how you're doing things, I want you to really stay pretty neutral. If I see when you go to initiate, the first movement is that wink in the butt and the extension,
right?
I know.
Which is very common.
Very, very common. Yeah. Or it's the opposite. Somebody that doesn't have good biomechanics here, their very first movement might be to go into flexion as they start to squat. So, but if I see you hyperextend there first, but everything else looks good, I know you're going to be rough at the end of the set.
Yeah.
Without seeing that stuff, it makes it harder to tell.
Gotcha.
You follow me?
Yeah. So it's another way to peek under the hood, right? Because like you said, you're watching somebody squat and it may look great. You can see some you can't really see some of the stuff's going on, or I don't know where your starting point is anyways.
Yeah.
Right. So it's good to kind of get a different view from that.
And likewise, as you were talking about, if somebody's had chronic issues, it doesn't mean throw in the towel and move on.
Yes, that's drive that home because because I see people, it's like, my back's bothering me, I should stop.
Yeah.
That tells me I should stop working out. And it's the complete opposite.
Yeah, and Dr. McIntosh and I have always talked about this. The better you know something, it's usually, it's not the 80% that makes the big change, it's the 1 or 2% tweaks. Like it's that with you, and it might mean that I have to put my hand on your hips and follow you through the squat a few times till you find that body awareness. I might need to rock tape you so you can feel that hyperextension. But do a little brain training on your squat, and all of a sudden, hey, you know what? I lifted heavy and didn't feel it all the next day.
Yes.
Right?
Which is a fun place to be.
Yeah. Don't throw the baby out with the bathwater.
Right.
Just get another set of eyes on things or get some eyes on it.
Okay. All right, I'll put those two together and how far that cut off. All right, we had a little bit of an issue in the recording there. I'll try to put these things together. Hopefully it flows pretty well. So the intent for this episode was to kind of peel back the layers of the onion to understand what low back pain actually is and why we're experiencing what we're experiencing. What we're going to do in the next episode is dig into some self-screening tools, some things you can do to say, hey, I'm not turning on my abdominals, I'm tightening my thoracic spine, or whatever the case is. So we'll do some self-screening tips, and then we're going to follow. I love the mobilize, lengthen, activate, integrate model. We're just going to continue with that, and we'll help give you more information on that. All right? See you next time.
Thanks.